Welcome to your high-yield rapid review for Mental Health Exam 2. We are going to focus on the exact safety protocols, pharmacology, and nursing priorities required for clinical competence. To manage the volume of material, we will organize this review into 4 core clinical modules: mood and suicide in red, substance use in orange, anxiety and OCD in blue, and somatic symptoms in purple. Strictly separating these categories prevents clinical errors, where a correct intervention for one disorder is mistakenly applied to a patient with entirely different physiological needs. In psychiatric nursing, identifying the correct clinical category immediately tells you whether your priority is physical safety, medication administration, or psychological support. We start with the red quadrant: mood disorders and suicide. When a patient presents with active suicidal ideation, your absolute physical safety priorities are initiating one-to-one observation and ensuring the patient's hands remain completely in view at all times. This chart compares standard depression treatments. While first-line SSRIs are generally safe, tricyclic antidepressants, or TCAs, carry a severe risk because they are highly lethal at low doses. If a TCA must be prescribed to a high-risk patient, you must enforce strict nursing interventions. You never dispense more than a 1-week supply, and you must perform strict mouth checks during medication administration to prevent the patient from cheeking and hoarding pills for a future attempt. In depressive disorder care, strict physical safety protocols and means restriction always override basic pharmacological administration during an active crisis. Moving to the orange quadrant, let's look at the alcohol withdrawal timeline. The clock starts ticking the exact moment of the patient's last drink. Initial symptoms emerge between 4 and 12 hours, but the peak danger zone, where delirium and seizures peak, hits between 48 and 72 hours. To manage this timeline safely, nurses use the CIWA assessment tool. Scoring specific symptoms like tremors, sweats, and agitation dictates the exact frequency and dosage of acute detox medication needed to prevent a fatal seizure. Let's test your active recall. If your patient is in acute alcohol withdrawal right now, do you administer chlordiazepoxide or disulfiram? You give the benzodiazepine, chlordiazepoxide. Benzos are the gold standard to suppress acute withdrawal seizures. Disulfiram is an aversion therapy drug used strictly for long-term maintenance of abstinence after the patient is already sober. If you need to reverse an overdose, remember your specific antidotes. Naloxone is for opioids, while flumazenil reverses benzodiazepines. Keep in mind, flumazenil must be pushed slowly because a rapid push can instantly induce severe seizures. Mistaking a maintenance medication for a detox medication can lead to a fatal clinical outcome. Always verify the current phase of the patient's withdrawal. Entering the blue quadrant for anxiety and OCD. If a patient is having an active panic attack, your immediate priority is to stay with the patient and decrease environmental stimuli. Do not leave an unstable client alone. This calendar illustrates pharmacological timing. Benzodiazepines deliver immediate relief for acute autonomic symptoms right now. Conversely, SSRIs and Buspirone are maintenance medications that take weeks to reach therapeutic levels. For obsessive-compulsive disorder, the clinical mechanism is a continuous loop. Intrusive thoughts, or obsessions, drive up severe anxiety. The patient then physically performs repetitive actions, or compulsions, to temporarily relieve that distress. In anxiety-related disorders, the timeline of the patient's distress dictates whether you implement immediate grounding techniques or establish long-term therapeutic planning. Finally, the purple quadrant, somatic symptoms. The foundational rule for somatic symptom disorder is that the nurse must treat the patient's physical pain as 100% real, even when all diagnostic tests are negative. Here is how you differentiate complex mind-body presentations. In conversion disorder, an acute emotional trauma directly converts into a physical deficit, like paralysis or blindness. This is often accompanied by labile indifference, a strange lack of concern from the patient about their sudden symptom. Compare that to factitious disorder, where the patient intentionally fakes an illness for the internal psychological motivation of assuming the sick role. Malingering is when a patient fakes an injury strictly for a tangible external or monetary reward. Effectively caring for somatic disorders requires you to identify the patient's underlying motivation rather than just treating the surface-level physical symptom. Let's initiate CRAM mode. These are the critical clinical points you need locked in. active suicidal ideation with a plan, priority intervention, one-to-one observation. Primary danger of a TCA prescription, high lethality at low doses. Peak window for severe alcohol withdrawal and seizures, 48 to 72 hours. Antidote for benzodiazepine toxicity, flumazenil, administered with a slow push. Instant reflexive recall of these safety triggers and antidotes ensures you prioritize the most critical physiological needs in a crisis. This visual map consolidates the 4 core modules. Take a screenshot right now and use it as the primary framework for your final study sessions. Mapping clinical information into these specific, prioritized buckets provides the clarity needed for success on exam day. Good luck!